All right. Good afternoon, everyone. My name is Saloni Singh, and today I'll be talking about the cardiovascular station in an OSCE format. So thank you very much for joining us today for the BIDA Student Wing's OSCE webinar series. Feel free to ask questions as we go along with the session. Right, so the learning objective for today is to talk to you through the steps of the cardiovascular examination, the signs that you should be able to recognize, and also the peripheral vascular examination. And finally, I'll also go over what sort of questions you should ask the patients if you're taking a history for chest pain. So general rules of an examination is start with introducing yourself, who you are, and then move on to asking the patient who they are and also confirm their date of birth. Ask how they'd like to be addressed. It's polite and it will help you have a bonding with the patient throughout the examination. Ask why they're presenting today. So just a simple question. Could you tell me a bit more about why you're in clinic today? And then explain that you're going to perform this examination to have a better understanding about why they're coming in or the cause of their problems. Then take consent. So for example, for cardiovascular examination, you should talk about, today I've been asked to perform a cardiovascular examination, and what this will involve is inspecting your hands, face, legs, and I'll also be listening to your chest and your back. Would that be okay with you? For this examination, I'll ask you to undress from the waist above. Is that okay? So make sure you tell them everything they'll need to do for the examination as you go along, and then start with a general examination of the patient's bedside and of the patient themselves before jumping into the specifics of the examination. And then, so for cardiovascular examination, you need your stethoscope. Make sure you wash your hands, you clean your stethoscope, and then make the bed at a 45-degree angle. Make sure the patient is comfortable at rest as you're examining them. So for general bedside, check for some of these things. So are they do they have an oxygen mask on or a nasal cannula on? Are they attached to any cardiac monitoring devices? Do they have any medications on the bedside, especially GTN sprays, aspirin? And come closer to the patient and have a look. Are they clammy? Are they short of breath? Are they in a lot of pain? And comment on that. Moving on, look at the patient's hands. So first you start with inspection. When you inspect the patient's hands, just look for any peripheral cyanosis, that is blowing off the tips of the fingers, and also check for clubbing. It might not be as severe as this, so you just ask the patient to put their fingers together like this, and if it forms a diamond-shaped window like it does in this image, then you say that they have clubbing. You also check for signs of endocarditis, which is splinter hemorrhages, Janeway lesions, Osler's node. So make sure you can hold the patient's hand to have a look. So make sure you're looking at the nails, turn their fingers, and check for all these nodes on their fingertips, on their palm. And also feel for the temperature of the hands. Is it too cold? Is there a variation between one hand and the other one is too warm or too cold? And tell the patient, I'm just going to squeeze the tip of your finger. Would that be okay with you? And check for capillary refill time. So you press for about 5 seconds. And if the capillary refill time is less than 2 seconds, that's normal. So moving on, you inspect the arm. So you're feeling for the radial pulse. And you want to check the rate. So this varies from university to university. Ask what they would want you. Are they okay with you checking the rate for 15 seconds and then multiplying that by 4 to get the heart rate? Or would they like you to do it for a whole minute? Comment on the rhythm of the pulse. So is it regular or irregular? And also check radio-radial delay. So what that means is you feel the pulse on both the arms and make sure they're both synchronous. Then you do collapsing pulse. So for this, make sure that the patient is not in any pain in their arm. So just ask them, I'm going to lift your arm rather quickly. Would you be okay with that? Do you have any pain in that arm? So you feel the radial pulse with one hand, and with your other hand, you feel for the brachial pulse. Then, as you can see in this picture, you swiftly lift the arm up. If there is a collapsing pulse, you will feel the pulse through the muscle where you're holding the hand here. And you just offer to check for a radiofemoral delay. So if the radial pulse is synchronous with the femoral pulse, and also offer to check the patient's blood pressure on both their arms. So moving on, you inspect the patient's face. So here, you ask the patient to just pull their lower eyelids down and you check for pallor of the conjunctiva. So this one is nice and pink. Here you can see it's white. So that's pallor of the conjunctiva, which indicates anemia. You will also want to check for corneal arcus, so this white line around there, and also for fatty deposits known as xanthelasma around the eyes. So these indicate high cholesterol. On the face, near the cheeks, you can see a malaflush, which is seen in severe mitral stenosis. So comment on that if you see it in a patient. Around the lips and their tongue, if it's blue, it's central cyanosis. And also check for high arched palate, which is seen in Marfan syndrome, which has a lot of cardiovascular complications. Next, you want to check the neck. So here you want the patient to be lying back at their 45-degree angle, which they are already, and then ask them to turn towards their left. You want to look between the two heads of the sternocleidomastoid muscle, and you'll see a small pulse. Usually it's very faint. It might not be seen in a lot of people until you really concentrate on it. But if it is raised in a patient, comment on that. So here's a video. So you can see the raised pulse about there. So usually if it's more than about 4 centimeters above the sternum, when you measure it, then it is known as raised. So next, move on to the chest examination. So here you're looking for scars, any chest deformities, any pacemakers like you can see here, and comment on that. Look at the side as well, as there can be scars on the side or even at the back. You want to palpate the chest. So here, let the patient know that now for this part of the examination, I'm going to place my hands on your chest. So the patient is not startled as you just go on and place your hand on their chest. Make sure you warn the patient before you do that. So what you want to do now is feel the top of your sternum, run your hand down to the sternum. You'll feel a bulge, which is known as the sternal notch.
I'm sending it back.
Sorry, could you please mute yourself?
I'm sending back the top of the skirt from Club of London because the skirt.
That's all right. So here, when you feel the bulge on the sternum at the top, that's the sternal notch, and that corresponds with your second rib. Right under that is your second intercostal space. So you want to go down all the way to the fifth intercostal space, just in between the clavicle, and feel for the apex beat. So you're just feeling for the heart, the rate, rhythm, and then move your hand to the left if you can't feel the apex beat there. If you're moving to the left, it means that the heart is enlarged and there's hypertrophy of the ventricles. So comment on that the apex beat is displaced to the left. You also want to feel for heaves and thrills. So you can either place your one hand like that, or you can place it side by side. And a heave is, you can feel the heart beating really strongly against your hand, and that means the heart is enlarged. A thrill is when you can feel vibrations on your hand with every pulse. So that happens because there's a murmur because of valve problems. So for the next step, which is one of the most important steps of the cardiovascular examination, you want to listen for heart sounds. So you start with the mitral area, which is your fifth intercostal space, mid-clavicular line. Listen with your diaphragm, and you're listening for heart sounds. So on the next slide, I'll make you listen to different heart sounds. So you want to make sure these are normal. If there are any additional sounds, any murmurs there. Then you move on to the tricuspid area, which is your left sternal edge, fourth intercostal space. Then your pulmonary and aortic areas are your second intercostal space, right, left on the pulmonary area and right for the aortic area. So some universities may expect you to also do the movements that will make the murmurs louder. So for mitral stenosis, you remain in the fifth intercostal space, mid-clavicular line, and ask the patient to hold their breath and expiration. A tip that I was given when I was learning this is when you ask the patient to hold their breath, make sure you hold your breath as well, so you don't forget to tell them to breathe normally, because that can sometimes happen. It's good if you just remember to remind them to breathe normally. And for mitral regurgitation, place it fifth intercostal space, but mid-axillary line. So go down to the axilla, ask the patient to turn towards the left, and that will make, if there is a murmur, it will make it louder and easier for you to recognize it. For aortic regurgitation, you place it left xiphy sternum, which is at the end of your sternum on the left edge, and ask the patient to sit up and lean forward towards you. So that will help you to listen for any aortic regurgitation. And finally, for aortic stenosis, you want to place it on the neck near the carotids. Ask the patient to hold their breath in expiration, and you should be able to hear for a murmur. Finally, for carotid brewery, you just want to ask the patient to hold their breath in inspiration, and you will hear the brewery. I'm just reading the questions here. Do you feel? So the heave can be, Mr. B, you can tell us, does the heave have to be on the ulnar side of your hand, or can it be anywhere in your hand when you feel for it?
No, no, what you said is right. There's another way. That's all I was saying. Another way you can feel the heave is, place the ulnar side of the hand on that area.
Right, just like that.
You can feel it another way, that's all.
All right. And yes, for mitral regurgitation, make sure you go up to the axilla and hear there, because that's where the murmur will be best heard. So these are some of the sounds. Let me know if you can hear them. Can you hear those sounds? So I'm sure you can recognize your normal heartbeat. So at this level, as a medical student, they won't expect you to know the exact murmur it is, but just be able to differentiate what is normal and what is not normal. So if I play the other ones, I'm sure you will be able to tell that it doesn't sound like a normal heartbeat here. So this is a systolic murmur. What that means is that after your first heartbeat, you can hear this swish sound. So that's a systolic murmur. And then you have your second heartbeat. It's the same for aortic stenosis. So how you will be able to differentiate between the mitral and aortic systolic murmurs is the place where you're listening to. So if you're listening in the mitral region, that's your mitral murmur, whereas if you're listening in the aortic region, that's your aortic murmur. And finally, a diastolic murmur will happen after the second heartbeat. Once again, I'm just reminding you guys that you don't have to know which murmur it is, as long as you can differentiate between a murmur and what a normal heart sound should be like. So moving on. Finally, you want to listen to the back, to the lung bases. So just go to the end of the lung base, and listen for any crackles. So what this sounds like is as if you're opening Velcro. And if you can hear it on both sides, that usually indicates fluid in the lungs. You also want to press on the lower back. So just take your thumb and remind the patient again that I'm just going to press on your lower back and press down there. So there'll be a pit. So you call that pitting edema. Same goes for the ankles. You press, make sure that you're gently just pressing there, and then you will feel, you can see the pitting edema. And finally, check for any scars. So that's for vein harvesting there. So finally, to conclude your examination, finish that with an S bar. It's a good habit to start early, so you guys will be very fluent with it as you go on with the years of medical school. So situation, I was asked to perform a cardiovascular examination on Mr. X, who is 50 years old. He came in with chest pain. The examination was unremarkable. That means that you did not find any abnormalities. Mentioned the heart rate. So it was 70 beats per minute. It was regular, and you could not hear any heart murmurs. And to conclude your examination, give some recommendations. So you offer to check the patient's vital signs, including blood pressure, respiratory rate. You want to perform an abdominal examination to check for any abdominal aortic aneurysm, to hear for any renal brewery, and finally finish the examination with fundoscopy to check for rod spots. So that was cardiovascular examination. Does anybody have any questions about it before we move forward with it? All right, feel free to pop the questions in the chat box if you have any later. So again, peripheral vascular examination, have your stethoscope ready, make sure the patient is on the bed at a 45-degree angle, and ask for a chaperone. Because for this examination, you'll ask them to uncover the entire arm, the entire leg, and also uncover the chest and abdomen. So they're basically just in their underwear. So make sure you have a chaperone and tell them that I'm going to call in a chaperone to make sure that you're comfortable during this examination. Would that be okay with you? If the patient says, no, I don't want a chaperone, then make sure you record that in your notes that the patient declined chaperone. So moving on, general bedside examination, take a step back, look around the patient's surroundings. Usually in an OSCE setting, they have a walking aid, which will be hidden somewhere in the corner. And as a student, you should be able to spot that. So again, cardiac monitoring devices, any walking aids, any special shoes for neuropathy, any medications around the bedside, which is quite similar to the cardiovascular examination. And finally, any amputations, for example, any missing digits, any missing legs, hands. Then do so a good way to remember your peripheral vascular examination is start with inspection, then palpation, then auscultation, and then your special tests. So for inspection, you check both the upper limbs and the lower limbs, and you do all of these for both. So peripheral cyanosis, check the fingers, check the toes, pallor of the limbs, any tar staining, so look at the edges of the finger there, any gangrene or any missing digits, and any mottled skin. You will also want to check for any ulcers, especially between the toes. So during the examination, make sure you're parting between the toes and mention to the examiner, I'm looking for any ulcers between them. You want to also comment if there is a Charcot's foot, which is seen in diabetes, and it's usually deformed like that, and it's warm to touch. Any signs of any skin changes, which is associated with diabetes, and also with venous insufficiency. You can have this darker, thicker, shiny skin known as lipodermatosclerosis. You don't have to remember all of them for your examination, but if you do, it's good. So moving on to palpation, you have to check all the pulses in the body. So start with your hands, move up to your neck, and then down to your chest, and then your legs. So start with the radial pulse. Again, feel for rate, rhythm, check for radial delay, and actually check for radiofemoral delay. You can check for radiofemoral delay either now or later on when you do your femoral pulses, but remember to check for that. Then feel the brachial pulse on both sides. So all of these pulses should be on both sides. You want to comment on the carotid pulses as well. Do they have a good volume? And I'll show you how to check for abdominal aorta on the next slide. Femoral pulse. So the location is from your anterior superior iliac spine, which is this bony prominence of the hip on the side, to your pubic tubercle, which is in the middle of your pelvis. Halfway through that is where you feel for your femoral pulse. Make sure you feel for it. Warn the patient, I'm going to place my hand near your groin. Would that be okay with you? And then popliteal pulse. So for this, ask the patient to bend their knees, relax it, and try to feel for the popliteal pulse. If you're not able to feel for it, that's okay, because sometimes it can be difficult to feel for the popliteal pulse. And then end it with feeling the posterior tibialis, which is on the medial aspect of your ankle, just behind the malleolus, and the dorsalis pedis pulse. So just ask the patient to point their toe upwards, and you'll be able to just run your finger down. You can feel the pulse there. And finish the palpation bit by checking the capillary refill time and also feeling for temperature on both your arms and your legs. So make sure you do all of this on both sides. So abdominal aorta, you want to place your hands about 1 centimeter to the side and 1 centimeter up from the umbilicus on both sides. Just push it down like that. Normally with every pulse, your hand might just go up a bit, but if there is an aneurysm, your hand will move outwards as if it's expanding. So if that happens, you will describe it as an expansile pulsatile mass, which indicates an abdominal aortic aneurysm. Then auscultation. So there are three things that you want to listen for. Carotid brewery. So ask the patient to take a deep breath in, hold their breath, and listen for any brewery. Renal brewery, which is about 1 centimeter to the left, or 1 centimeter lateral and up from the umbilicus. And finally for femoral brewery. Again, tell the patient, I'm going to place the stethoscope in your groin. Would that be okay with you? To end the examination, you might have to perform additional tests depending on where you go to, what your university requires. So one of them is called the Berger's test, which is used to check for blood supply from your arteries. So you ask the patient if they have any pain in their hips. If they do have any pain in their hips, then don't perform the examination. If they've had a hip replacement surgery, then don't perform the examination and mention that to your examiner. Otherwise, move forward with the examination. Ask the patient to relax their legs, lift their legs up to 45-degree angle and hold it for about a minute or two. Normally, for people who don't have peripheral vascular disease or arterial insufficiency, the leg will remain pink, but if they do have it, it will go pale. Once that happens, ask the patient to sit up, hang their legs to the side, and the color should return. When the color returns, it might turn very red, which is known as reactive hyperemia. So that's the sign you're looking for if they have arterial insufficiency. Finally, you want to check for varicose veins. This is best examined when the patient is standing up. So ask them to stand up. Make sure that you're also looking at the front of the leg and the back of the leg. Don't miss that. Sit down, get to the level of the leg and look at it. And check for any bulging veins, like you can see in this picture. Either offer to check for incompetence of the saphenofemoral junction or check it yourself. So what that means is you go about 1 to 2 centimeters below and about 1 centimeter inside from the femoral artery. Place your hand there and ask the patient to cough. If you feel something against your hand, then there is incompetence of the saphenofemoral junction. Otherwise, it's normal. So again, to conclude the examination, perform S-bar, where you will say, I've been asked to perform a peripheral vascular examination on Mr. X, who is a 70-year-old male. He presented with pain on walking in his legs. The examination was unremarkable. His heart rate was 70 beats per minute regular, and capillary refill time in all limbs was less than 2 seconds. On palpation, all the pulses were present and strong on both sides, and on auscultation, no bruise were heard, and Berger's test was negative. Mention all the bits of the examination, how they're normal. If they are not normal, what is not normal with them. And finally, offer what else you would like to do. So you want to, again, check all the vital signs, including blood pressure. You want to check ankle brachial pulse index. You want to perform a cardiovascular examination and peripheral nervous system examination, especially if they have any ulcers or problems with their legs. And finally, end it with a Trendelenburg's test. So that's everything for peripheral vascular examination. I know it seems like a lot, but the more you do it, the easier it gets to learn all of it. So finally, for chest pain, do you guys have any ideas of what sort of questions you'll be asking the patients? If you can just pop it in the chat box, the different things you'll ask patients. Yes, Socrates. That's very good. Anything else? Anything specific? For example, for Socrates, what sort of questions will you ask for associated symptoms? So what else can go along with chest pain that will make you worried about? Yes, shortness of breath. That's very good. Yes. So these are all good points. So yes, you follow Socrates, which is site of the pain. When did the pain start? Were they doing something when the pain started? What is the character of the pain? So could you please describe what the pain feels like to you? Usually if it's something to do with a heart attack, they will say it's crushing, it's heavy on my chest. And radiation. So especially ask, where does the pain go? Does it go down your arms? Does it go up to your neck or your jaw? And also ask, does it go to your back? Does it feel like it's traveling from your chest all the way to your back? So what are the symptoms do you have? So first, just leave it open. Ask the patient, what symptoms do you experience along with the chest pain? If they say nothing, then ask them these specific symptoms. So do you feel like your chest is tight? Do you feel like your heart is beating really strongly in your chest? Do you feel like it's racing? Do you feel clammy or sweaty? Are you feeling dizzy? Do you have any problems breathing? And then ask them what factors make it worse. So is it walking around, going up and down the stairs? Is it better, the chest pain, is it better when you're resting or when you take a tablet under your tongue or a spray in your mouth, which is usually the GTN spray? And also briefly ask them about any medical conditions they have, especially any problems with their blood pressure, any problems with their cholesterol levels, any diabetes, any drugs that they take every day. Are they allergic to anything? Do they smoke, consume alcohol? And are there any medical conditions that run in the family, especially any heart conditions? And ask them what they're worried about. What do they expect from this visit to the doctor? And then you present it as an S-bar. So this is just an example. You can just say whatever you find in your history taking. So here, your situation is summarizing the first bit of your history, which is your Socrates. Your background is what medical conditions they have and whether they're smoking, they're smokers, what risk factors they have for heart disease, and if they've had any previous surgeries. Then your assessment here will be, what do you think your working diagnosis is? Are you worried about acute coronary syndrome, which is usually a heart attack, if that's something you're worried about? And your recommendation is, after this history, what else would you like to do to aid your working diagnosis? So you want to perform an examination of their heart, so cardiovascular examination. You want to perform an ECG, send some bloods, and take it from there. Is that all right for everyone, or does anybody have any questions? Yeah, so Mr. B has said that patients usually don't realize they have pain in their chest. Sometimes they just say there's a heavy pressure on their chest, like a band constricting their chest. So sometimes they might not directly say it's pain. So it's best to ask what they're feeling. So if you have any questions, pop them in the chat box. Otherwise, could you please fill this feedback form for me? I'm just going to send it in the group now. And we'll stay here for about 10 minutes if anybody has any questions. Our next session is on the respiratory system. And if you have any suggestions for how we can improve next time, please put it in the feedback form. Thank you.
You've stunned them to silence, Saloni.
But I hope they found it useful. I know it's a lot to take in.
Yeah, no.
So I'm just... So this is the feedback form. I'd really appreciate it if you guys could please fill it in. It will take less than a minute. And once you're done, you can join us next week and have a nice Saturday and Sunday. Yes, we'll upload the copy and a recording of this session onto our website, which is BIDA-StudentWing.com. So it should be there about within the week.
they're all leaving.
Yeah.
Yeah.